Next topic is on TNM classification. So this is a universal staging classification for cancer. T stands for tumor, N for lymph nodes, and then M for whether or not there is metastasis. So for T, it can be TX. TX is not necessarily good or bad news. TX is we don't know, meaning we can't say yes, we can't say no. Zero is better. T0 meaning there is no evidence of a tumor. TIS, there is a tumor, however, it is in situ. In situ means it's either encapsulated or it's stationary. Okay, so most likely benign. T1, T2, T3, T4, this is now the size of the tumor. Now there's no T2000 or something, right? So it stops at around T4. This is subjective here, meaning a T1 in the brain, is that the same size as a T1 in the abdomen? Probably not, because there's less space in the brain. Okay, so let's say, can I have a T4 in my abdomen and put it into the brain? Not the same size, because that'll be too big for the entire skull. Does that make sense? Okay, so this will become a little subjective. So let's just say T1 is small, T2 good size, 3 that's quite big, and then T4 will be like, damn, okay, that's big. All right. For lymph nodes, this one will be a number. So there's really, because you can have multiple lymph nodes. Let's say you have 7 lymph nodes, then that'll be N7. All right. So they literally count how many lymph nodes are involved. Lymph nodes, of course, represents the lymphatic system. So tumors can grow in lymph nodes. So once they spread, meaning they enter the lymphatic circulation, then they can spread to multiple lymph nodes. And just like tumor, and NX is we don't know. We have to do other tests to really make sure. Okay, so right now it's NX, we don't know. N0, that's good because there is no lymph node involvement. And like I said, the number will increase corresponding to how many actual lymph nodes are involved. M will describe the metastasis. So this will be SEM, of course, MX, we don't know. M0, this is good news. There's no evidence of metastasis. M1, yes, there's one, but statistics-wise, this can go up to N7. Bronchial, lung and bronchial cancer have been known to spread to up to 7 different organs, usually 6. No, let's say if you have lung cancer, it can be spread to the breast, to the bone, to the liver, to the rectum, even to the brain, right? Let's go now to management. So how do we treat cancer? Because immunotherapy require and the biologics, including monoclonal antibody treatments, are quite expensive and are therefore are out of reach of the common person, unless you have insurance, health insurance, like what Congress has, for instance. Okay, they have excellent coverage. So you and me are probably stuck with um, the 3 traditional treatments, which are surgery, chemotherapy, and radiation. Okay, so that's all we'll test. Let's start with surgery. So this is the oldest treatment. So before we discovered chemotherapeutic agents and the radiation invention of the radiation therapy, there was just surgery. So if you had a tumor, what did we do? Take it out. Okay, surgically take it out. Of course, when we say surgical removal of the tumor, what can we actually remove? Because let's say it's a malignant tumor, which is tightly adhered to the host organ. Can we remove the heart? So when we say surgical removal here, we're really talking about non-vital organs, right? Let's say a breast, a testicle, no, some non-vital organ, all right? So a leg, for instance, an ear, one kidney, maybe one lung, right? Okay. There are also different purposes of surgery. Not all surgical treatments for cancer will cure cancer. Some of them are for diagnostic purposes. Okay, number one example here is a biopsy. Another is Another purpose of surgery is for treatment. Now, treatment can be to cure. That's the ideal purpose. However, for treatment, it may not be possible to remove the entire cancer because let's say it's attached to a vital organ like the brain, for instance. Of course, you can't remove the brain. But however, can we debulk it? Meaning, can we resect a good chunk of that tumor to safely, preserve brain tissue? Yeah, that's possible. That's still treatment though, right? Although it's not cure, but we reduce the size of the tumor. Okay, we shaved off a good chunk of it. Okay. And that can relieve a lot of symptoms. Let's say there's no more headaches, for instance, no less pain and less vomiting, less seizures, for instance. Okay, so because those are things that people with brain cancer deal with. So that can be another purpose. And there are examples here. So for the exam, I may pluck one or few examples, okay, and then have you identify the purpose of the surgical procedure. I won't read the examples, you're responsible for that. The chapter gives you good examples. And I'm not testing the type of, because there are different ways, meaning techniques of doing surgery. Let's say, have you heard of cyberknife? That's like bloodless surgery. They use radiation therapy to shave the tumor, okay, without cutting you at all. Okay, no scalpel involved. Okay, they use radio surgery. They use radiation, laser. So there are different types. Another type of surgery is prophylactic. What is prophylactic? Prevention. Okay. Number one example here is if the patient has polyps, for instance, colon polyps. Now, colon polyps are not cancerous per se, but they've been known to develop into cancer. So if they see polyps during a colonoscopy, they'll go ahead and remove them. That's an example of prophylactic. And these are some factors that they'll consider for you to undergo prophylactic surgery. And there are 6 bullets here. So we've got colectomy, mastectomy, oophorectomy. So these are examples, right? What did Angelina Jolie undergo? Bilateral mastectomy, yeah? So that's prophylactic. So she technically didn't have cancer. So she got them removed and then got new ones. Palliative, now, when you hear palliative, usually you associate this with hospice, right? That's not entirely true. Yes, palliative care is always part of hospice, but it doesn't have to mean you're at end of life. Okay, so we can consult palliative team at any time during your treatment. So whenever it involves some pain or discomfort, for instance, to improve your quality of life, we can consult palliative care anytime. But here, when they say palliative surgery, the purpose of the surgery is not to treat or cure the cancer. This usually involves some inoperable tumor. Know that you'll die if we take out the tumor. So this would simply be the surgery is done to improve quality of life. Only symptom management. Okay, that's the whole purpose of the palliative surgery. Reconstructive. So example again, breast surgery. So let's say you lost the whole pectoralis major, plus also it involved let's say the areola, so you have no more nipple. So we can do reconstructive surgery to create a new nipple, right? Or let's say your face was so the face, you know, it was so deformed because of the surgical removal of the tumor, so we can reconstruct it. Okay, make you your appearance acceptable to you. For nursing care for patients undergoing cancer surgery, it's not really different from what we did already for the pre, intra, and post-op chapter. It's really the same. So I'm not going to repeat that. It's really the same. Okay, there's no special care for cancer surgery. Does that make sense? Because you prepare the same person, you know, the same preparations for any other. However, in today's cancer management, one treatment is seldom used. It's usually a combination. So let's say if a patient undergoes cancer surgery, that means they may be followed with chemotherapy and or radiation as well, right? Or sometimes radiation and chemo will go first to reduce the tumor size, and then they go undergo surgery. Okay, it's usually a combination now. Because with cancer surgery, there's a chance that when they cut the tumor, some cells fall off. No, yes, you cut the tumor, but there are some cells that are, we call it seeding. Okay, so they may drop off and then they'll continue to spread. So to finish them off, that's why they use combination treatment. So they'll add chemo as well as radiation at the same time. And again, pre and post-op care, the same. You know, the complications after surgery, respiratory depression, stroke, heart attack, DVTs, pressure injuries, wound dehiscence, and eviscerations, same. Okay, pre and post-op care. Including wound infections, UTIs, you know, pneumonia, all complications of post-op surgery, post-op care. Any questions on surgery? Very good. Let's go to radiation. There are two forms of radiation. We've got external beam radiation, which is external radiation. And then we've got internal radiation. Internal radiation has two subtypes. We have sealed and then unsealed radiation. So let's do external radiation first. The concept of radiation is exposing the person to radioactive material. And once the radiation is absorbed by the cancer cells, unfortunately, though, normal cells will also absorb the radioactive material. So yes, they will kill cancer cells, but they'll also kill normal cells. Okay, so there's always collateral damage with this type of treatment. However, if we compare radiation therapy from the 1960s, 1970s to radiation therapy today, it's clearly different. So radiation therapy today is more precise, not only precise with the location, but they're also precise with the dosing. Okay, so we've come a long way with radiation therapy. For example, in 2004, when I saw a breast cancer patient, she had radiation therapy. Her whole chest from her neck down to her belly button was burned. She had dermatitis. So all looked so red and angry, moist. Okay, so it literally was burned. So they took a shotgun of a radiation treatment to her. It's only the breast, but then it involved the neck down to her belly button. So you won't see that anymore today. So it's very precise. Okay, they can only target the tumor. So maybe a small section of your breast, the breast will have skin dermatitis. Okay, so it's way different today.
What is the purpose of the involvement?
Again, we expose the cells, again, both cancer and normal cells to radiation. They die. It kills the cells because it interrupts with, no, basically you're poisoning the cells by exposing it to radiation. However, keep in mind that they won't all die today. Some cells will die today. More will die later on tonight. More tomorrow because they absorbed it. Okay? So not all cells will die like right now. But so this is what we mean by once we use radiation therapy to treat you, because it's absorbed by all other cells in the body, can you develop cancer in the future? Yes, a different type of cancer. You remember hyperthyroidism last semester? There was radiation treatment. Okay, so that was a form of unsealed radiation therapy. Okay, so that was internal radiation, unsealed type. So let's discuss how external beam radiation works. Okay, so let's say I'm the cancer patient. So let's say I have lung cancer. So I'm gonna go, let's make it my neck. Okay, so I have, say, uh, laryngeal cancer. So I go to the cancer treatment center, radiation center, and they will make a mold of my head, because when they position me, they want to make sure that the beam only hits maximum target will be the cancer tissue, the cancer tumor. However, can we only target the tumor, or will it also hit my skin, the muscles underneath there, and then my trachea? Yeah? Okay, so it will hit it. But we'll try to minimize it by holding my head in a certain position. So to make sure, once they find the precise position, so let's say this angle right here, and I lay like this is perfect. Okay, when they put the beam right here, that's great. Keep it like that. Can I hold this position until, when I come back tomorrow or next week? No. So they'll make a mold. So put plaster over my head. So that creates a mold, right? So the next time I come in for treatment, I lay down, they just put that mold, and I'm forced to assume the same position because that was the face of my head and neck. Okay, so that makes sure I'm precisely in that exact position as we did the last time. All right, so they'll do that, and then of course, that means I'll have some burn injuries here, so I'll have severe dermatitis. Can I also have trouble swallowing and speaking, maybe? Yeah, okay. So I'll have to put some burn ointments on my neck, and probably because I can't swallow, will I need a peg tube maybe short term? Yeah, so they'll probably give me a peg tube, and they'll do that, of course, before treatment, so I can know, okay, how do I handle this? How do I do feeding? Okay, and they know I won't be able to swallow, right? So those are preparations involved with, and it's specific again for each type of treatment, depending on where is your cancer located. Okay, where do we put the radiation? Okay. Depending, I'm not the radiation oncologist, so they will prescribe the type of radiation, the dose, the duration, and the intervals. So, yeah, no problem. So, like I said, some cells may die immediately, but some will die later, tomorrow, next week. Dosage is determined by three factors. One is the distance. How far is the radiation source from the patient's body? Time is the next factor. Time is the duration. How long was the exposure? Again, first is distance, time, and then there's the shielding. Now, shielding will be, of course, do I necessarily have to expose the rest of my body, especially my testicles, to the radiation? No. So I'm gonna have to wear protective lead apron. So they'll put it, you've seen this in when you go to the dentist, right? You get a dental x-rays, they'll put a heavy apron over you. So same thing. Okay, so we'll protect the rest of your body. For me, of course, I'll put it right here over my pelvis. Okay, I'll protect the McNuggets. Okay, I don't want any future damage in that area. So that's external beam radiation. Any questions? Okay. So when I go home, When I leave that treatment area, did I bring the radiation with me? No, the radiation source was in that room, that treatment center. So they exposed me to it. My body absorbed it. I didn't bring it home. It stayed right there. I'll come back, see it again next week or tomorrow. So with external beam radiation, there's really no need for any precautions, okay, for external beam radiation, EBRT. For internal radiation, that's a different story. Because what do you remember last semester? So let's talk about radioactive iodine 131, RAI 131. So what did the patient do to it? Did they swallow that thing? Yes, they swallowed the radiation, and then so therefore they swallowed it so that it enter my entire body. Yes, it went systemic because my GI tract absorbed it, and then it went to my thyroid gland. So because I'm radioactive, do I have to exercise radioactive precautions? I have to, because anything wet coming out of me is radioactive. So my saliva, reproductive secretions, feces, urine will be radioactive. So, except of course tears and sweat, they usually are harmless. Okay, so I have to, of course, remember the isolation, meaning can I share utensils, towels, toothbrushes? Do you share toothbrushes? Well, maybe you mistake it, okay? So you have the toothbrush looks like yours and then you grabbed it. Diapers, okay? So patients incontinent, be careful with those. Toilets, let's say you share a toilet, make sure you wipe the seat down, flush it 2 times. Wash and dryers, okay? So washing machines, we have one in the household, yeah? So you have to run it empty, okay? One cycle to rinse out all the radioactivity. Um, yeah, and then of course, can you have so what's the distance and time precautions we have to observe? So if I have radioactive iodine 131, so that's unsealed, yeah? So it enters my body fluid. So how far can I safely stay from the patient? Actually, it's 3 feet. It's 3 feet, and how long can I stay close? Up to 1 hour total. 3 feet, 1 hour. The reason is when it's unsealed radiation versus sealed radiation. An example of sealed radiation is the the radioactive material is inside me. Let's say it's in my breast, it's in my cervix, it's in my bladder, but we will retrieve it later, right? So therefore, there's some container for the radioactive material. So let's say we put it in a tea bag and put it into the breast or inside the cervix. Then we have some string or something to pull it out with. Then we'll take it out. Okay, so that's a sealed radiation. They seal it because the dose is usually higher. So sealed, higher radiation, unsealed, lower radiation. So that's what you keep in mind. So if it's unsealed, lower radiation, so how far can I stay closer? Because that's a smaller dose. Yeah, lower dose. So I can stay 3 feet from that patient. And then I can also spend up to 1 hour total. If it's sealed, however, higher radiation. So how long can I spend with the patient? 30 minutes now. And how far can I stand? 6 feet. Does that make sense? Okay, so just remember which one is a higher dose, sealed or unsealed?
Yeah.
Sealed has a higher dose. So you stay 6 feet, spend 30 minutes total. Now, of course, don't spend that 30 minutes or that 1 hour continuously. Okay, so you have to spread it out for the whole shift or for the entire day. So can you sleep with the patient? Let's say this is your spouse. Can you have sex? Can you wear a condom? No, there's no lead condom. Okay, so you cannot protect yourself from And you have sex with a selfie, selfie stick? No, right? Doesn't work. So no, there has to be abstinence. Okay, you can't because there's exchange of body fluids, and again, you can't protect yourself from, from the body fluids. Yes.
So question, if, when the patient has these sealed radiation, do they leave the hospital that day?
Yeah, we have them at home. So we have several patients who have them, who live at home. Let's say you visit them when you do home health. So you'll visit some of them, like they have the implant right here in the breast. Yeah, they're at home.
I was gonna ask if they had it done at the hospital, how would they get home? Because if they had some family member drive them home, wouldn't they be too close to that family member?
Oh, they can sit in the back seat.
That would
Something
be
like that. Yeah.
acceptable distance.
Yeah. But somebody has to drive you. Sorry. The
become small, like shrink.
no. I mean, there will be collateral damage. That's the whole point of radiation therapy. We're trying to kill the cells. So unfortunately, again, we can't distinguish, cells and normal cells versus the tumor cells. So everything will be killed around that area. So let's say example, when you have radiation to your jaw, for instance, or your neck. So of course your teeth will be involved and the jawbone as well. So you'll probably have some dry mouth because your your salivary glands will be affected. They'll be destroyed, and also your teeth. You may have poor dentition. You'll have dental caries. You'll lose some teeth. Okay, so those are examples of sad side effects with the treatment. And for me, for that, dry mouth will be worse. Imagine your mouth being dry, no saliva. Imagine that. How are you gonna eat and swallow? You have to add water all the time. Put a burger and then chase it with water. Because otherwise, how do you swallow? Hey, be like a rock. So that's the whole point of radiation therapy. Any questions? For sealed radiation, it's just the distance and time. There's really no worry about the body fluids if it's sealed because they don't enter the body fluids again, meaning it will just make the surrounding tissues or body parts. There's of course there's damage there. For let's say if it's in the cervix, they put the radioactive material in the cervix, then they probably have diarrhea, some bladder, issues. So just imagine the location, okay, and then the possible damage there. For instance, you have one in your breast, right? So let's say you have a sealed implant in your breast, so that will affect your lung as well, or even possibly your heart. Okay, so that may cause an inflammation of your pericardium or the pleura, for instance. Let's say you'll have pneumonitis, even pericarditis. It really depends. The side effects will depend on the location. Where did we put the radiation material, the radioactive material? For toxicity, these are unfavorable unintended symptom or condition with the radiation treatment. So I gave examples already. No collateral damage to the surrounding tissue. One thing is systemic is fatigue. Radiation patients always complain of fatigue. Now, some fatigue may be explainable. Let's say it will affect the bone marrow, right? Yes, anemia will explain the patient's symptom of fatigue symptoms. However, some patients may have perfectly good blood counts, meaning no bone marrow suppression, but they still complain of fatigue, even though the treatment only takes maybe 2 hours, 1 or 2 hours, a few days a week. They still complain of fatigue. Okay? That's something we can't really explain. And again, depending on the location, you'll have some alopecia, okay, your hair loss. Let's say it's the radiation is to your head and neck area, so that can affect the hair in addition to your teeth and your salivary glands. And one thing in common again, because it affects the skin, right? Because you have to hit the skin in order to hit the tumor. So there's always dermatitis, which looks like burns. Here, radiodermatitis. Okay, this is very painful. You have to protect that skin, put sunscreen, don't expose it to ultraviolet rays. And the skin will never heal the same, just like your hair. So once you lose your hair to cancer, it'll grow back. However, it may not be the same hair as before. Okay, so it'll never be the same. It'll look different now. So they were damaged by the radiation. Same for your skin. So that part of your skin may never look the same as the rest of your body. There are also mucositis. By the way, the side effects here for radiation will be the same when we talk about side effects for chemotherapy. Okay, because it's the same. They're absorbed. Chemotherapy is just as toxic or cytotoxic as radiation therapy. Okay, so whether you swallowed a pill or you swallowed a radioactive material or you were exposed to radiation or we injected IV chemo into you, it's the same systemic absorption. Okay, so therefore the side effects will be the same, right? However, generally speaking, when we say radiation, as long as it's external radiation, is the side effect systemic or local? If it's external radiation, local. But whenever you swallow or inject the medication, it's now systemic. So you'll have more side effects. So let's talk about the hair. Is hair important? Yes, especially in a female patient. Okay. So I already talked about these decreased salivation or xerostomia, no saliva at all, or loss of taste. Loss of taste, and how are you gonna enjoy food? Yeah, you don't know what it tastes like, so you'll eat anything. Or that is if you have any appetite at all. Mucositis is another painful side effect. So have you had canker sores? You know what I'm talking about? When you bite your lip or tongue sometimes, and then you have a sore there. It looks white, yeah. So imagine those canker sores the size of a quarter or the size of a dollar coin. And it's not just one, it's multiple. It's in your gums, it's in your cheeks, it's in your tongue, it's in your throat. Why? Because the GI tract, our mouth, all the way to the rectum, are rapidly dividing cells. Okay, you notice how when your lips chap, does it stay chapped for a long time? Overnight, it's gone, right? That's how fast your GI tract cells divide. So therefore, they're affected highly by radiation and chemotherapy. So you'll have these mouth sores. Okay, how are you gonna eat now? It's already bad enough that you don't have any saliva. Makes it worse is you have painful sores in your mouth. So for that, of course, we have to give them mouthwashes, specialized mouthwashes. It's usually a cocktail of saline. Do you know what benzocaine is? No, like Orajel. Yeah, when Orajel, it numbs your teeth, right? So the same thing. So there's Orajel. There's benzocaine in it, saline, and then they may add some antifungal medications there because it's usually common when you have mouth sores, you get fungal infections in them. Yeah. So it's a combination. So you swish, and if you have them in your throat, you'll be advised to swish and swallow. If the throat is not involved, then you swish and spit. Okay. So you do that before a meal, and then you feel good, less painful, and then you can eat. Because if you don't eat, then what will happen? You're a cancer patient. You're receiving treatment. You don't eat. You won't survive the treatment. You need to be well nourished. Okay? You need to be strong to survive the treatment. Here, more GI problems. We'll talk about the nausea vomiting separately because that's really a huge problem. And then we got bone marrow depression as well. So you'll have anemia, thrombocytopenia, neutropenia. And among the three, the most serious is the neutropenia because you'll be exposed to infections. Of course, you have many portals of entry. You have these mouth sores, plus you have the dermatitis if you receive radiation, or let's say you have a central line if you're receiving chemo, right? So plenty of portals of entry for infection. And then you have neutropenia on top of that. So of course, you're high risk for sepsis, right? That's why we put under COVID or under septic shock. What was the people at risk? Cancer patients, yeah? I mentioned the fatigue, the malaise, and these are the acute symptoms. We haven't done the late effects yet. Okay, so there are more effects. So for late effects, we're still in radiation. These are let's start with the skin. There's loss of elasticity. That's why I say the skin will not look the same as before treatment. Then you may develop fibrosis, atrophy, ulceration, necrosis. Look at these organs affected: the lungs, the heart, central nervous system, the bladder. So whatever you do, don't get cancer. All right. So protecting caregivers, we discussed already the distance and duration of exposure. Okay. Again, distinguish between internal. So this part here is talking about sealed radiation because the example for unsealed is already in the thyroid chapter for our AI 131. So this part here will be for sealed radiation. So 30 minutes daily and 6 feet. Any questions on radiation? Alrighty, let's go straight to chemo. So chemo, in radiation, we use radioactive materials. Here, we use basically poison. So there are many types of radiation. We have a table before we get to that. So these are the action. So whatever type of chemo drug you're using, there are some antibiotics which are used for chemo. We have alkylating agents, we have antimetabolites. Okay, so whatever type of chemo drug you're using, they do the same thing, which is the goal is to interrupt the cell division. Remember mitosis, there are different phases, right, in the cell division cycle. Okay, so different drugs target different phases of the cell division. So just like radioactive radiation, so they will affect cell division. So they destroy cells. Cells cannot divide, they cannot multiply, and unfortunately, they will affect all cells of the body. So that's why there are GI symptoms, because again, GI tract cells are lined with single layer epithelium, rapidly dividing, just like your bone marrow. So your bone marrow multiplies millions of times each day, yeah, producing platelets, red blood cells, and white blood cells. And is this always used alone? No, usually it's combination of radiation or even surgery. Okay, so you have an idea now of what cancer patients are going through. Or if you've survived, let's say cancer, good. You're strong, you survived these. I'd probably just curl up and die if I have to undergo the same thing. So I won't test the the cell kill cycle. Again, it is nice to know. We'll focus on the side effects and then the management of those side effects. This won't be long because it's really the same as in radiation therapy. We're dealing with the same things. Right. There will be no chemo drug questions meaning no chemo drug specific questions on the NCLEX, meaning they won't tell you, they won't ask you, okay, what are you doing with this? So, meaning you don't have to study the drug, but you do need to be familiar with the name. What do you need to do? Familiar with the name, meaning you need to recognize, that's a chemo drug. Okay, because once you know that it's a chemo drug, what are the side effects? It's the same as radiation. So your care will be the same. Another reason is during your first 12 months at work, which is the practice analysis that the NCLEX will base the questions on, 0 to 12 months experienced nurses. You're typically not chemo certified during your first year because you need to go for BSN. So you need a BSN before you can go for 6 months of chemo education to become chemo certified. And once you get that certification, you get like $4 or $5 more per hour, okay, depending on your hospital. Let's talk about dosage. Again, we're not administering this, okay? However, we are going to care for a patient who is receiving chemotherapy and radiation. Is that clear? Meaning we won't administer the radiation, we won't administer the chemo, okay? However, we are taking care of them while they're receiving these treatments. Okay, so let's start with dose. Have you heard the term nadir? NADIR? It's not exclusive to chemo. It's actually a concept. So what does nadir mean? It's a period of time. It's a period of time. It's a time period wherein something is very low. So let's say I'm financial nadir right now because payday isn't until Friday, and I've got $10 in my wallet. So I'm in a financial nadir. Does that help? Okay, so nadir is what? A time period wherein something is very low. So in cancer, in chemotherapy, the nadir here is the time period wherein your blood counts are at their lowest. Each chemo drug has a specific nadir, but generally speaking, most chemo drugs have a nadir of 7 to 14 days. So average about 10 days, yeah? About 2 weeks. So if you receive chemotherapy, IV chemotherapy, you think you'll be given that daily? No, because you will have a nadir period of 10 to 14 days. Okay, so let's say even if it's 7 to 10 days, you still need a break, correct? Because if we give you chemo continuously, what will happen to your blood counts? You'll die. Okay, so you'll die from infection, you'll die from anemia, you'll die from bleeding, okay, from thrombocytopenia. So therefore, we have to space it out. So a typical chemo dose is usually 2 weeks. So once every 2 weeks is the treatment. Why do we spread it out? Why not get it over with and kill that cancer? We can't because we'll kill the patient as well, right? So therefore, we give the patient a 2-week break, 2-week period for their bone marrow to recover. Because once they get an infection, can we continue the treatment? That's it. We have to stop the treatment and then we have to start over. That is if you survive this infection that you're having. You already know about sepsis, yeah? So that's higher risk. So when you have sepsis, yeah, you know the story. You know what happens to the inflammatory, systemic inflammatory response syndrome, the capillary leak. Okay, so and then the complications, yeah, you get DIC, and then there's ARDS, right? So it's not easy. All right. So therefore, we give them a 2-week break between doses. All right. So that's because of what concept again? The N word, nadir. Okay. This one you're also responsible for, especially this one. What happens is, so let's say Lavi is chemo certified. She works on the 4th floor. And I'm a med-surg nurse, and my patient is receiving chemo. The doctor ordered, okay, so patient's sick, but they want to continue treatment. Okay, find a chemo certified nurse, administer, let's say cisplatin. Administer cisplatin. So can I give it? I'm not chemo certified. So supervisor will be notified, hey, find a chemo certified nurse. So they found, okay, lobby's the closest one to you. We'll call lobby. Lobby, we have a patient here who needs chemo. Can you do it? Sure. So she'll give report to her because she has her own job. Okay, so she has her own patient, so she'll give report to, momentarily for a couple hours. Okay, hey, here's my patient. Right, and then she'll come down to my floor and give the drug. Okay, she's the only one certified. Okay, so she'll hang it, give it, and then she'll educate me on what to report. Part of her education is about extravasation. So how will I know that there is extravasation already? What is extravasation? It's basically infiltration. So the drug, because your IV access no longer is in the vein, so now the drug is leaking around the tissues. Now, chemo drugs are very vesicant. They will cause tissue necrosis. Literally, they will kill tissues, like they'll burn tissues, okay, causing necrosis. And these can go deep into the muscle, okay, and then causing a very, very bad wound, right? Which will take years or at least a year to heal. So do we want that? No. So it will cause tissue destruction. And these are the drugs known to cause extravasation. So these drugs here are very vesicant, right? So therefore, they ideally should be therefore given through a central line, meaning a large vein, the subclavian, the femoral, or the jugular, for instance, something big. That way they don't extravasate. But sometimes we do give it peripherally, although that's extremely rare. I've only had it probably happen in my 29 years. I've only seen a IV chemo administration twice, right? And that was the most stressful shift for me because every 10 minutes I'm in there watching the patient's IV. Because have you seen extravasation? Is it what it, is it what it looks like? Look at that. So these are mild, the ones you see here, but this is the start. So after that, it will turn black, and that's black tissue, like necrotic tissue. So the doctor has to surgically cut it, and then it becomes a very deep wound. Then it will take months or even years to heal that wound, and you'll be deformed. The body part will be deformed. So the degree of tissue damage depends on how long did it Yeah, how long did it occur? So if I see that patient only once an hour, what will happen between now and the next hour if it was extravasating? It's too late. It's now spread. Let's say it's running at 60 mLs per hour. So that's a lot of drug into the tissues. Okay, so that you can understand why I was in there every 10 minutes. Okay, because if it does extravasate, at least I caught it early, right? And it didn't happen on my watch. Or at least I took care of it early. And so it's not pretty. It's a nasty wound, not to mention very painful. So again, chemo is only administered by who? Okay, chemo certified nurses. Okay, so not you and me. None of us here are chemo certified. However, Who's responsible for monitoring for extravasation? Every RN. It falls on us, so we need to know what it looks like. Okay, so we can stop the transfusion, I mean the infusion, and then call the nurse. This is not testable. Okay, again, that's not what the questions will be, but what do you need to know? The name. So look at these names. So for me, how I would survive is if it's not a cardiac medication, I know cardiac medications. I know thyroid medications. I know parathyroid. I know kidney. I know diabetes. So if it's nothing like any of those, what must that be? That must be a chemo drug. Yeah. Right. So just look at the names. Some of them are antibiotics, and some of them were also some like cyclophosphamide. You saw that under rejection. Yeah, remember? Organ rejection, transplant. Okay, and then of course, ideally, chemo drugs should be administered through a central line, really, so that we don't have to worry about extravasation. For bone marrow suppression, what is our worry again among the three? Anemia, thrombocytopenia, and neutropenia. Which one is priority? Neutropenia. That's your most serious complication because that will interrupt treatment, okay? Potentially kill the patient. Of course, we also address anemia because the patient has no energy level, no activity tolerance, and then finally bleeding. So what drugs are given? Okay, so for anemia, what's the drug we give? Erythropoietin, Procrit, or Erythacrit. Okay, so there are different brand names for erythropoietin. Then we've got for platelets, it's Oprelvicin. This is for platelets. And for what's the drug for what blood cells? Filgrastim. 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 Probably seen it on TV. The brand name is Neulasta and Neupogen. Neulasta is pegfilgrastim because it's long acting, not long duration. Short acting is Neupogen, which is filgrastim, and then pegfilgrastim is long acting. They come in those, you'll see them, like those CGM machine implants, wearable, or like Dexcom. Yeah, it looks like Dexcom. Okay, so you put it on your skin. It has an adhesive. It delivers the drug. Okay, so that's Neupogen or filgrastim. Same also for Prelvikin. Erythropoietin though is a sub-Q injection. You give that once a week, 20,000 units. Who else received erythropoietin injections besides cancer last semester? Dialysis patients, yeah? Hemodialysis patients. So here are a few more damages. But as far as the most common, nausea vomiting. Remember the non-antiemetic drugs we discussed in post-op chapter? Okay, so same thing. I'll ask you about the same thing because that's how we address it. For mucositis, of course, can we use commercial mouthwashes like Crest or Listerine? No, those things will stink. Anything with alcohol will burn that patient's mouth and throat. So it has to be the special prescriptions. Okay, so the doctor will prescribe what's in the oral rinse, and then the pharmacist will mix it. All right. And alopecia, of course, can they wear a wig? Okay, so when should they be advised to pick a wig? before or after they lose hair? Before or after? Because is it if they lose hair or they're gonna lose hair? They're going to lose the hair. So when do we pick a wig? Before or after? Before, that way you can get ready, right? Oh, I want this. Okay, so because you don't want to go out, let's say you're in Central Park, okay, you have got bald patches here, and then next week, the next day, you have beautiful hair. Oh, that's a wig. At least you can hide it, right? So you're starting to lose hair, you already have a wig on, so nobody has to know, right? You can go continue working, you can stay in school, okay, if you're healthy enough, right? Nobody has to, you don't have to, you don't want to be, the subject, right? People talking about, hey, you know what? That's a wig. Hey, that's a wig. You know, really, go pull it, go pull it. Kids do that. Like my kids were small because they knew their grandma had a wig. I did not put them up to it. May have given them the idea, but I didn't tell them to do it. There's also chemo brain. Now, this is a natural phenomenon. Patients' IQ drops. Like you literally, your IQ, you get dumb. Okay. Good thing though, this is not permanent. So as soon as you finish treatment, your cognitive abilities return. Chemo brain or chemo fog. It's a real thing. Fatigue, you already mentioned. For full electrolytes, this is because of the diarrhea, nausea, vomiting. Okay, they have fluid and electrolyte abnormalities, so same management as in chapter 10. So these are some long-term complications. So we talk about the dry mouth, the teeth problems. There's also decreased libido. Chemo, again, we're not giving the chemo. We're just concerned about what? Extravasation. And what are those signs of extravasation again? So here it is. There are 4 bullets actually. No, they only have 3. Okay, so 3 bullets. Absence of blood return from the IV. Again, the extravasation is usually for a peripheral line. Okay, we don't see extravasation in central lines. Resistance of IV flow and then burning or pain, swelling, or redness. There. Okay. What do you do when you see these? Stop the infusion and who do I call? The doctor or the chemo nurse? I'll call the chemo nurse, okay? Because she's the expert, or he or she's the expert. Here, you stop it immediately and call the chemo nurse, and then she'll decide if she needs to call the doctor. Because if you're a chemo certified nurse, you know the antidote, okay? You know what to do, and they have this extravasation kit. Nausea, vomiting, again, as I said, same drugs, there's a table, right, under the post-op chapter. So there were, I think, 5 different drugs there, or was it 6? Right, so same. For cell transplant, stem cell transplant. So this is an option. So this is dangerous though, because this is how it works. So let's say I have leukemia, right? So the cancer is in my bone marrow. If I do stem cell transplant, meaning I'll give the patient somebody else's bone marrow. Right now I have leukemia. If you put somebody else's bone marrow in there, what will happen to that bone marrow? It'll just be, yeah, same thing, because it will just be outnumbered by my leukemic cells, right? So what we'll do is The patient therefore has to have their bone marrow eradicated. How do we do that? Large dose chemo and radiation. So the patient will be given large dose of chemo and radiation, wiping out their bone marrow. Is that dangerous? Yes, I'll have severe anemia, severe thrombocytopenia, severe neutropenia, but that's what we're going to do. We have to wipe it out. So therefore, can we do this outpatient? No. Patient will be in the hospital, isolation, private room. We'll do the treatment. And then finally, when the patient's blood counts are extremely low, then we'll implant the stem cells from somebody else's bone marrow. Okay, so allowing it, we call that engraftment. Now, the patient's not out of the woods yet because that bone marrow that we remember rejection. Okay, so in rejection, what did we do to the donor and the host? We immunosuppress them. Now, this time, it's not a solid organ though. This is a tissue that we're going to implant, right? What if there are active lymphocytes in that graft? What would they do? So can I reject it? So if I'm the patient who's extremely immunocompromised, can I reject the graft or will the graft kill me? It'll be the opposite now. It'll be graft versus host now. It's not organ rejection anymore. It'll be graft versus host. So can I die? Yes. So therefore the doctor has to be careful that they wash, not in laundry, but when we say wash, that we eliminate all active lymphocytes in that sample. Does that make sense? Because otherwise it will kill the host. About spills. So here's let's say we have a spill of chemotherapeutic drug. Chart 12.5, 12-5 tells you what to do. Okay, do not clean the spill with your ordinary gloves. There are special gloves for chemo agents. All right, you'll get injured, you'll hurt yourself if you don't handle them correctly. Okay, we have chemo spill kits in every unit, but don't even attempt it. Okay, so just let the chemo nurse do it. Okay, they're the experts. They're trained to do that. So here's GVHD, graft versus host disease. So this is better prevented because it's not easy to treat. Treatment is still the same as rejection. We still give the patient immunosuppressants because the lymphocytes are already inside the patient's body. So we do the same thing. We do immunosuppression. Does that make sense? But the manifestations are usually skin. Let me show you what it looks like. There will also be liver manifestations, but the largest signs and symptoms you'll see is on the skin, like this. That is, okay, so this is what graft versus host disease will see. Okay, so if you have immunocompromised hosts, and then they develop GVHD, and this is all over the body, especially around the trunk, but it was also spread on the extremities, but mostly on the back and the torso. Scary too. Let's go now to the emergency. We'll skip immunotherapy. Okay, this is specialized treatment. Remember, I mentioned these are very expensive. Yeah, you and I probably can't afford this. So let's go to the okay, so here's the stomatitis I described already. We have is that the cocktail? Okay, so they'll have some oral rinses, especially prescribed by the physician. This will affect, again, nutrition. Patient won't eat. It's too painful. So for the skin, we again, because there is radiodermatitis, very painful, very red, very wet, very sore. Care for it would be moisturizing soap. Don't put any skin products that are not approved by the radiation oncologist, so they'll tell you. Usually lotions would be the more expensive ones, like Eucerin, Cetaphil. No, the mild ones, definitely not Jergens or what are the other Gold Bond. Okay, so nothing like that. So it's gonna be the very mild products. Of course, no tape, okay, nothing, no tight clothing, so your spandex won't be usable. Here's alopecia again. Take note also the hairless scalp. So let's say the patient chooses to wear their baldness proudly, right? They don't want to use a wig. Now, is the scalp prone to injury? Yes, so tell them to take care of the hairless scalp. Okay, so put sunscreen on it too. Okay, moisturizers, just like the rest of your body. Okay, because it's prone to injury as well. Can get sunburn. For if it's skin lesion like melanomas, for instance, so same thing, same skin care, protect it from sun exposure, cover them. Nutrition, so we again promote the patient's appetite. That won't work. We have mucositis, so make sure they use the oral rinses regularly. Otherwise, it'll be too painful to eat. Patients will be given nutritional supplements, Boost, Ensure, Glucerna, whatever is applicable. Same thing for anorexia. There are medications to promote appetite. Problem with them is the one drug that promotes appetite is Megace. I don't know, Megastrol, Megestrol, Megastrol. That thing will cause DVTs though. No, so it's not really no, and widely used because of that side effect. Oh, pain management. I won't repeat this. We did pain management last semester. So morphine, more long-acting types. But they'll also benefit from short-acting for breakthrough pain. Fatigue, I already mentioned earlier, under radiation. So these are the sources of fatigue. Again, usually from bone marrow suppression, but other possible causes are anxiety. Okay, so depression and even insomnia. Okay, basically stress. Okay, and then pain, discomfort. So that's will cause and contribute to the fatigue. Sexuality. Who has libido when they're dealing with cancer? Yeah. Okay, so support both partners, okay, the patient and the partner as well, because having no sex, will that ruin relationships? Yes. Okay. Infection. Again, these patients are neutropenic. What are your interventions for neutropenia? Can you bring in fresh fruits, uncooked foods, salads, cheeses, sushi, fresh flowers? Okay, last part is the emergencies. Okay, there are 6 oncologic emergencies, but on the table here are only 4. Table 12-13, so we got 1, SVC syndrome. Second is spinal cord compression. Third is hypercalcemia. And then fourth is tumor lysis syndrome. Okay, there are 6 though. 5 and 6 are not on this table because they've already been mentioned in other chapters. You remember sepsis and DIC. So that makes 5 and 6. Make sense? Okay, so DIC is not here. DIC is in chapter 23. No, 25. And sepsis is, of course, under shock. So how am I testing this? So when we talk about emergency, what does that mean? These conditions are what? Life-threatening, yeah? Patient will die. So this will result from either the cancer itself or the treatment for cancer, meaning radiation or chemotherapy will cause this. So what do we need to know about something life-threatening that can occur? Let's say I'm your cancer patient and I'm your cancer patient. I'm at risk for these. So what will you need to know? Signs and symptoms and what do you do? Right? Okay, that's it. So look at the 4. So the signs and symptoms are in the second column, and then management is on the third column. Right? So let's say here for SBC syndrome. So what causes this? So this is compression of the superior vena cava. So what types of cancer will cause SBC syndrome? Lymphoma, right? Lymphomas or any other tumor in my lungs, for instance, right? Or let's say I have lymph node involvement, metastatic tumors anywhere in my torso, and it's close enough to the superior vena cava, it will compress the superior vena cava. So what will happen if my superior vena cava is compressed? What will I look like? Will I have edema? Where? In my upper or lower part? Upper part of my body. Okay, so I'll have a swollen face, edematous. Will I have distended veins here? Yes, in my chest and also my shoulders. And on my face, I will have distended veins there. Can I have shortness of breath? Can I go into shock? Because what happens to cardiac output here? There's less blood coming from the upper part of the body. So therefore, cardiac output will drop. Is this shock? Yes. What type? Cardiogenic or obstructive? This is obstructive shock. Make sense? Okay, and then what else will I have? Distended neck vein. So what will I feel on my head? Because there's so much blood in my head, can't drain because my superior vena cava is compressed. So headaches, increase ICP. Vomiting, seizures, yeah, okay. So those are your manifestations. And what to do? Well, after calling the doctor, so you expect to have radiation, chemo, right? Or if the patient's in shock, then they may have to do surgery. Okay? Obstructive shock. That's it. Let's go to SBC, spinal cord compression. So this one is any tumor, primary or metastatic tumor in the spine, right? So this one is, of course, compressing my spinal cord. So what would be manifestations? So if I have spinal cord injury, what will I have? Can I have paralysis? Weakness? Yes. Can I have back pain? Yeah, okay, there you go. Can I have some bowel or bladder problems? Yes, depending on the level of injury. So spinal cord compression. Is this spinal cord injury, basically? Yes, it's basically spinal cord injury. What do? Third column, right? And you also have some sexual dysfunction here as well. Okay, again, depending on the level of spinal cord compression. Next, hypercalcemia. Where did this calcium come from? Why did my calcium levels rise? Remember hyperparathyroidism last semester? Same symptoms. So where did this calcium come from? Destruction of what? Of what? Be specific. Where is my calcium found? In my bones and in my teeth. Okay, so therefore, what type of cancers can cause this? Bone cancer. Okay, either primary or metastatic bone cancer. All right, these are my manifestations. So manifestations of hypercalcemia, same as hyperparathyroidism. And what were the treatments again? If you recall, hypercalcemia, fluids with diuretics. What else? Calcitonin. Biphosphonates. Yeah, like alendronate, bisadronate, amidronate. Yeah, yeah. You're still taking the NCLEX, so you can't escape, right? You need to review those. Okay, and then finally for tumor lysis syndrome. Now, unlike the other five, this one is not all bad news. This is good news. So the doctor will say, okay, I got good news and bad news. So the good news is if you have tumor lysis syndrome, the treatment is working. The tumor is being destroyed. Okay, it's working. The cancer treatment is working. The cancer is being destroyed. It's being eradicated. The bad news is you could die. The cause of death here, because cancer cells, their contents, are they really different from normal cells? The same. They contain potassium, and when destroyed, they produce uric acid. Yeah. So those are the problems of the patient. They'll have hyperkalemia and hyperuricemia. Hyperuricemia can potentially damage their kidneys. They go into AKI, intrarenal AKI, and die, or they can have a cardiac arrest. Okay, they'll have a heart attack or other serious dysrhythmias, okay, from the hypercalcemia. So what were the treatment for hyperuricemia again? We did gout last semester. What were those treatments? Colchicine, allopurinol, okay, probenecid. And then for hyperkalemia, how do we lower potassium? Calcium gluconate, sodium bicarbonate, regulate insulin with dextrose, albuterol. Okay, and what's the oral or rectal? Oh, sodium. No, don't do generic. We have to do generic. Okay, so Kexlate is brand. So what's the generic for Kexlate? Sodium, polystyrene, sulfonate. Okay, very good. And then what's the newer one? We have patiromer, right? That's a new Kexlate. Okay. All right, that's it for cancer.